Hi, everyone. We're going to get started here in just a second. Just letting some people get in. All right. Hello, everyone, and welcome to the ASCP Virtual Pathology Grand Round offering titled A Practical Diagnostic Approach to Neonatal Cholestasis, being presented today by Dr. Ivan Gonzalez. Today's offering will be recorded and offered for on-demand consumption, and participants have the option to claim one continuing medical education CME credit. Please stay tuned for more details via email on access to the recording and credit claiming instructions. I'd now like to go ahead and introduce our speaker, Dr. Ivan Gonzalez, who is an assistant professor at Indiana University School of Medicine in the Department of Pathology and Laboratory Medicine and the medical director of the Indiana University Health Histology and Gross Laboratories. He signs out both the general pediatric pathology as well as the adult liver and gastrointestinal pathology services. One of his many areas of interest is neoplastic and non-neoplastic liver diseases, and he is the Riley Hospital for Children site pathologist for the NIH-funded Children's Study of Pediatric Liver Disease. Dr. Gonzalez was also selected as one of the 2023 ASCP 40 Under 40. He enjoys mentoring and teaching the residents and fellows in the clinical services, as well as in several research endeavors. In his spare time, he enjoys spending time with his wife, Amanda, reading a good non-medical book, cooking, and cycling. Lastly, Dr. Gonzalez has no relevant financial relationships with ineligible companies to disclose. And Dr. Gonzalez, I will let you take it away.
Thank you so much, Mary, for that introduction. And thank you again to the ASCP committee for this invitation. I'm really excited to be talking about this topic that is very passionate to me. So let me first make it present mode. I think I need to swap the screens. Okay, now we should be good. This is a very challenging topic and daunting at the beginning when you start looking at neonatal cholestasis, those liver biopsies. And I think in part is due, one, the rarity, unless you're in a pediatric center, and how challenging it can be to approach those biopsies. So I hope in these 50 minutes or so, give you a practical approach to how to handle these biopsies. So objectives. So we're going to describe what is the approach to the neonatal cholestasis, recognize the differential diagnosis, and distinguish the different histologic patterns that we can see in these biopsies. So first, we'll start with some definitions. So jaundice is indirect hyperbilirubinemia, and it becomes clinically apparent when roughly you have a bilirubin level of 2.5 to 3 micrograms. Now, cholestasis is due to abnormally excretion of bile due to either an intrahepatic production, a transmembrane transport within the hepatocytes to the canaliculi, or a mechanical obstruction within the bile duct system. The conjugated hyperbilirubinemia we define it as a conjugated bilirubin more than 1 if the total bill is less than 5, or when it's more than 20% when the total bill is more than 5. And the neonatal cholestasis will be the cholestasis present at birth and or during the first months of life. It doesn't refer to the neonatal period, which is the beginning 28 days of life. It's just a cholestasis present at birth and or the first couple months of life. So what are the causes? There are over 100 causes of neonatal cholestasis, and we can divide it in groups. So first, obstruction. The most important cause of neonatal cholestasis in obstruction will be biliary atresia, which is really important to make an early diagnosis. We can do by infections, viral, bacteria, protozoa, autoimmune, such as gestational autoimmune liver disease, hereditary cholestatic condition, such as Alagille syndrome, progressive familial intrahepatic cholestasis or PFIC by abbreviation, hereditary metabolic conditions, for instance, carbohydrates with fructosemia, amino acid like tyrosinemia, mitochondriopathies, peroxisomal disease, bile acid synthesis disorders, others like idiopathic, and bile duct paucity when it's non-syndromic, with syndromic bile duct paucity being your Alagille syndrome. So as you can see, it's a very extensive causes of neonatal cholestasis. But of those, the most common ones, if we go to this study in 1989 by the King's College Hospital, the most common was idiopathic at that time point. But now, as we progress, and nowadays we do a lot of molecular studies in these patients, and including some cholestatic genetic panels. So that idiopathic causes are actually shrinking. And in this subsequent study by the Children Network from that time period in 2017, the idiopathic decreased significantly. We have new causes like prefix, bile acid synthesis disorder, and mitochondriopathies. So this number now is way lower now, and this current date, and that's just because of the more use and widely applicable molecular testing in these patients. So the most important things with all those differential diagnoses is finding those critical diagnoses. So what are those critical diagnoses? Biliary atresia. Why? Because in biliary atresia, as soon as you make the diagnosis, you want to do like a side procedure, which ideally you want to do in the first 6 days of life. So in this explant, I'm just showing an example of liver explant status post Kasai, where we can see here your hepatoportal enterostomy. If you have an extrahepatic obstruction, a mass, a lithiasis due to surgery, galactosemia, since avoiding the food with lactose. So all these important diagnoses are really important because they have a treatment will require an early diagnosis to avoid that patient to go into liver failure and needing a liver transplant. So how do we evaluate these patients? So first, clinical history. The gestational age is super important in these patients, especially when you're talking about premature. Maybe I go into a histology example why that is important. Physical exam, with the main attention is trying to find any dysmorphic features. In the cardiac exam, eye exam, that would be important, for instance, in Alagille syndrome. And laboratory tests, there's a lot of tests that we do in these patients, including your liver function test. And the liver function test, the most important value, in my opinion, will be the GGT, because based on the GGT, we can divide the differential diagnosis in two big groups. Of this, also remember, you also, at the same time, you're doing neonatal screening tests. As soon as the baby is born, you get the neonatal screening test. So by the time that you're working out this patient, most of those tests will be already resulted. That will help you a lot working out these patients. So the importance of the GGT, we can divide in low normal GGT and high GGT. So low normal will be progressive familial intrahepatic cholestasis, except type 3. Type 3 will be a high GGT. Other conditions will be bile acid synthesis disorder, also mitochondriopathies. So it's super useful when you're looking at a liver biopsy and you know the patient has a low GGT. So then your differentials start getting a little more narrow. Then once you combine that with your histology, hopefully you're able to provide your clinicians with a limited differential diagnosis. High GGT, one of the most important causes, biliary atresia, cholestasis, Alagille syndrome. And as mentioned again, PFIC3 will cause a high GGT. In contrast, the PFIC1, 2, and 4, which are more common, will have a low normal GGT. So what other studies do? We do also abdominal sonogram, and the main goal is to exclude any anatomic causes of obstruction. So it will detect any anatomical structural abnormalities. Findings suggested of biliary atresia will be an absent gallbladder or an atrophic gallbladder and a triangular cord, which is being shown here by this arrow. And that triangular cord represents that fibrotic plate that forms in the biliary atretic segment. Other studies that we can do is hepatic mammography, and it's only useful to rule out biliary obstruction. It just tells me that you're excreting bile. So as soon as this arrow will be the normal when you have excretion of bile, we're here in these contracts. So if that doesn't happen, you know you have some sort of obstruction. It doesn't tell you what. So there has a high number of false positives and even rare cases of false negative. So it's not a diagnostic test. And that's really important because in some centers, given the awareness of all these false positives, they require doing a liver biopsy before you go to a cholangiogram. So you get a hepatic mammography with a normal result. Before going directly to a cholangiogram, they will do liver biopsy just to make sure. For instance, one important false positive will be Alagille syndrome. So going to cholangography can be performed transcutaneous, intraoperatively, or endoscopically, and it is considered the gold standard for biliary atresia. But it has a false positive in more than 20% of the cases. And again, why sometimes it's very important in some centers, they will prefer to do a liver biopsy before doing this test. Because for instance, if you get an Alagille syndrome, your liver biopsy, you will diagnose your bile duct positive. And hopefully it will avoid taking this patient to the OR and doing a cholangography. Because then if it is abnormal, then the surgeon will refer to then do like a side procedure. And these patients will do very poorly with that clinical diagnosis of allergy. So knowing all those clinical labs, the imaging testing, what is our practical approach? This approach that I'm gonna present you now is practical and is generalizing a lot of concepts. And importantly, each center has their own unique practical approach. But in general, once you define your cholestasis, you evaluate your patient with a lot with these lab tests, for instance. Importantly, your DGT. So at that point, you get a specific diagnosis, you just treat that specific diagnosis. If not, then you go and you can divide your patient in two big groups, low normal GGT, high GGT. In the high GGT, you start doing some imaging study, astronomy. And then you detect, for instance, anatomic abnormality, cysts, a mass. Then you go the patient straight for surgery. Now, if that was normal and non-specific, then we go to another imaging modality. And you have biliary excretion, we say that we rule out biliary atresia, but then you still go and do a liver biopsy and start doing genetic testing to keep working out these patients. If you do not have biliary excretion, biliary atresia is still in the differential diagnosis, and then you perform a liver biopsy, which can show different histologic patterns, for example, hepatitis or an obstructive pattern. If you see an obstructive pattern, then at that point, this patient is going to be taken to the OR and do a cholangiography. And depending on those results, the surgeon may or may not do like a side procedure. Now, if you have a low normal GT, they will start doing a urine mass spectrometry, which is abnormal. Then you have your diagnosis of bile acid synthesis disorder. So this is a very practical approach and super useful when you are looking at this liver biopsy and trying to pull the entire story together for your patient. So liver biopsy, when to do it. The recommendation is performed when biliary atresia is suspected. And ideally, you want to perform this before taking your patient for a cholangiogram. So types of biopsy, you can do a needle biopsy, wedge biopsy. I personally am not a fan of wedge biopsy. I think wedge biopsy are more challenging to interpret because of all that subcapsular liver tissue. You over-assess fibrosis, for instance, and usually you get a more limited amount of podotract. So ideally, you want a needle biopsy. So you can do different types of needle. In a perfect world, you get a 16G needle biopsy, very long, 2 centimeter, like with multiple podotracts. The important is to know that one core of 20, like 2 centimeter length of using the 16G, it's approximately 15 micrograms of tissue. And if you want to do, for instance, like iron, copper, study quantification, you roughly need 2 to 3 micrograms. So just getting, for instance, a half of a core of a 16G will be enough to get those metabolic studies, like those quantification studies. And what is your ideal biopsy? You want to have more than 10 podotracts, and ideally in a perfect world, you want 15 to 25 millimeters in length. Then I'm showing this photo here. There's multiple ways you can gross these cases. You can use your mesh cassette. We here in IU, we don't use the mesh cassette. We just wrap it in tinfoil, like basically wrapping partition. My only advice would be never use sponges, because if you use sponges with a liver cord, you're gonna have a lot of artifact, and that will look really bad on histology. So you don't want to use sponges. That's the reason, the main point of having that photo there. So what is your routine processing? You do an H&E, you can do a Mason tricon, a Mori tricon, that's just lab preferences and your personal preference as a pathologist. Periodic acid shift with diastides, reticulin and iron stain. Other stains that you can do will be a copper and a PAS without diastates. In our lab, we do 2 H&Es. We get one Mason tricon, we get a PAS with diastine and one without the diastates, and then reticulin iron. That's just our own protocol here. We also get from the clinician one sample that is dedicated for electron microscopy. So we'll basically get 2 containers, one with 2 or 1 long core of liver biopsy, and then another one with a small fragment of liver that will be for electron microscopy. We process it. We just don't take the photos of the EM right away. We only take the photos if, based on the histology, we think we need it, or the clinician specifically requested to run the EM. But we already have it processed in case we need to do it in the future. Immunohistochemistry, you can do biliary markers like CK7, CK19, do kind of liquid transport proteins like BSEP, MDR3, intercellular junction proteins, and those will be useful in the workup of some of the differential diagnoses. So you got your biopsies. And you basically have three patterns. You can have an obstructive pattern, a giant cell hepatitis pattern, and a bile duct positive pattern. So we'll talk of each one a little more detail, how to diagnose those and the differential diagnosis for each pattern. So the obstructive pattern, this is a classic photograph of an obstructive pattern where you have your phototract expansion, you'll see photostromal edema, you'll see an extensive ductular reaction. And the ductular reaction is accompanied, as you can see here, by some pituitary neutrophil, like a neutrophilic infiltrate around the ductules. And very importantly, you have a lot of bile plugs. So you have bile plugs with your bile ductules moving. And also you have a bile duct proliferation. So for us in pediatric pathology, it's very important to denote the difference between a bile duct and a ductule. So bile duct should be entirely embedded within the phototract, and they should be surrounded by the stroma by connective tissue. Whereas the ductule will be located in the limiting plate, not within the inside the phototract, and not entirely surrounded by connective tissue. And the difference is, if you're working on a case, for instance, of bile duct paucity, and you're doing an official count, where you're actually counting is bile ducts, not counting the ductals. So it's really important for us to like get that difference. So other findings of obstructive pattern, you may or may not see a prominent cholestasis in the lobule, like here you have a lot of cholestasis, both hepatocellular and canalicular. You do not tend to see a very prominent giant cell hepatitis of the hepatocytes, and the main action is just happening in this phototract with the very exuberant ductular reaction, bile plugs, the neutrophils, and the photostromal edema. So what is the differential diagnosis? So pediatricia, with one of the most important differential diagnosis, given that critical early treatment. Cholestasis cyst as well. So in these two photographs, in the top photo, I have a pediatricia case and this is a cholestasis cyst. So in the pediatricia here, you can see the arthritic segment, and in your classic case, the actual gallbladder will be completely atrophic. This gallbladder is actually a little dilated. In here, in this cholestasis cyst, here you have your dilatation of the cholestasis duct. And important with cholestasis, all cholestasis are resected for surgery. They are divided in several subtypes depending on the specific anatomic location. That's a more radiologic clinical diagnosis, not so much from the pathology perspective. And the importance is that cholestasis are associated with a later progression with malignancy, with adenocarcinoma. That's why we always resect cholestasis. Other differential diagnosis, alpha-1 antitrypsin deficiency, Alagille syndrome, rare cases, and especially the initial presentation, particularly some cases, I've seen cases with NOSH2 mutation who have this ductular proliferation, bile duct proliferation, and not that classic example of bile duct paucity. Cystic fibrosis will have that ductular reaction, and sometimes you may even see within the bile ducts this mucus plug. Remember that cystic fibrosis, you got this very dense mucus because of that chloride transportation is abnormal. So that mucus can accumulate in the small intestine, for instance, in the crypts, and it will look like a cellular kind of dense eosinophilic mucus. So that you can also get it inside the bile ducts. So if you see that, that will explain your entire obstructive pattern, and you can also suggest to the clinician the differential diagnosis of cystic fibrosis. Very importantly, parenteral nutrition, and that a lot of these patients are going to be preterm. Some of them may even have intestinal atresia or necrotizing enterocolitis. So they're already in parenteral nutrition and then complicated with a neonatal cholestasis. And that will look exactly the same as a pediatrician. So you need to be aware of that. Remember to tell your clinician, this could be a TPN. You cannot exclude BA, and that's very important to tell them. And they need to just keep following the patient very closely. So we'll talk a little about pediatricia, given the importance of this diagnosis. So it's a progressive obliteration of the extrahepatic biliary ducts, roughly 1 in 10 to 20,000 live birth, and is the most common cause of neonatal cholestasis and of liver transplant in children. You can divide in three groups: those without any anomalies, those with laterally malformation, 10 to 50%, and those with other congenital malformations. Unknown etiology, there's a lot of hypotheses. Maybe it's an infection happening in utero, like the CMV, and then you have this autoimmune response against the bile ducts that then creates destruction. So the important thing is finding that diagnosis, because you want to do like a site procedure within 60 days of life. So if you do this Kasai within the first 30 days of life, your chances of that children needing a liver transplant within the first 3 years, 4 years is only 50%. But then once you wait and you do 30 to 60 days, that percentage goes down to 30%. So it's really important to get this as early as possible because that's one of the main important predictive factors of having a successful Kasai. So when you're doing the Kasai, you find your fibrous plate, and the surgeon will apply all these sutures and basically will like lift the fibrous plate and then cut underneath or proximal to it. And then at that point, they will attach your small intestine, creating that hepatoportal enterostomy. So your specimen in the gross bench, you can see that a lot of these suture, that will be their fibrous plate. The surgeon usually will orient it for you, but even if they don't provide you what it means, all the suture, when you see all these multiple of those, that will be your fibrous plate. So in this case, the fibrous plate is the gallbladder, and then here you have your bile duct. So you can, if you want, Inca in your grossing, as long as you identify and say which block is right. I don't think it's necessarily, but it's useful because once you section it, then you can rearrange it again and get it back to the anatomic configuration. So how to submit those sections? My recommendation would be to first your first section, your A1 or B1, being a shape section of the fibrous plate. And then you sequentially submit it from proximal to distal, considering proximal the fibrous plate. So all the way roughly where the common bile duct starts. And then at that point, then you switch direction and then you submit again proximal distal your entire common bile duct, and then proximal to distal your gallbladder. So yes, we're submitting an entire specimen. So that roughly end up being like 8 or 9 cassettes, because you can put multiple pieces in the same cassette, and those tend to be small. So in histology, these are 3 separate examples of a fibrous plate. In some cases, you may have a reactive lymph node, no, no lumens, or you may have a lot of vessels forming and this kind of stromal like edema. And in some cases, you may have a lot of small bowel structures, abnormally formed bowel structures. So the most important thing when you're looking at this biopsy is, can I exclude BA or not? And that's the most important to tell your clinicians. So findings that are not suggestive of pediatrician is bile duct paucity, a very prominent hepatocyte cell transformation shown in this photo, steatosis. Usually when you see fat in these neonates, you're thinking of metabolic conditions, and a very prominent lobular extramedullary hematopoiesis. So the way I approach this case, I try to tell my clinicians, I cannot exclude BA. You need to move forward with a client, you're gonna follow this patient very closely. Or I will say like, I think this is not BA. So that's the most important connotation when looking at these cases. Okay, so let's move to the second pattern, which will be the giant cell hepatitis. So the giant cell hepatitis pattern, as the name implies, you have a diffuse transformation of giant cells of the hepatocytes, and there will be a lot of cholestasis. And you can see here, there's a lot of cholestasis in the canaliculi, and then forming this biliary pseudoset or pseudoacinine formation with extensive cholestasis. If you look at the portal tracts, the action is not happening here in the portal tract, and that's very important. So you may see some little bowel prevention, but you won't see a prominent ductal reaction, no bowel blocks. You see that when you're talking about obstructive pattern. And you have a very prominent extramedullary lobular hepatopoiesis. Here in this photograph, I'm not showing that. And coincidentally, like the myeloid EMH will happen in the portal tract, and the erythroids will happen in the lobule. So for instance, in this photo, you have a lot of erythroid hematopoiesis, and it's all happening in the lobule. When in the portal tract, you will have the myeloid. The differential diagnosis is idiopathic infections, alpha-1 antitrypsin deficiency, such as in this case, PFIC, except type 3. Type 3, remember, is an obstructive pattern. Niemann-Pick disease type C. And in Niemann-Pick, you will see these classic cells, which will be vacuolated and clear Kupffer cells. And that is where the abnormal are being accumulated, and they will be positive for BAS and diastatic resistance. So we'll talk a little about PFICs. So these are autosomal recessive disorders present with hepatocellular cholestasis. The majority will present during infancy, and by definition, by the name implies, they can progress to end-stage liver disease. In the past, we used to classify them based on the G2 level as low and high. Currently, we just divide them based on the specific gene that is mutated. The first three recognized will be PIC1, 2, and 3. And this is like in the left side, you have the normal individuals. You have all these canalicular protein that are just helping screen those bile acids into the canalicular. But you can also have your junction proteins, and you have a loss, for instance, in TJP2, that if you lose that junction, then you are also losing that osmotic pressure that is helping the bile flow into the canalicula. So that will also cause an accumulation of the bile acids within the hepatocytes, causing damage. So in this table, summarizing some of those prefix. So here you can see your mutated gene, what is the protein that gets deficient, and the serum GT. A lot of these protein deficient, we actually have immunohistochemistry marker that we can target and assess for them. If you have the right clinical histologic picture, then you can go ahead and perform those immunostains. And you will notice here that a lot of them have the same histology. So for instance, canalicular hepatocellular cholestasis with a giant cell transformation pattern, basically a neonatal hepatitis or giant cell hepatitis pattern. In the PFIC1, you have a blind canalicular cholestasis in the central lobular area. And if you do electron microscopy, you will have a coarse and granular bile within the canalicular, which we term bilateral bile. So that pattern of the blind canalicular cholestasis is very similar to your BRIC, which is the benign recurrent intrahepatic cholestasis, which present in middle-aged patient, which is benign recurring episode of cholestasis that resolve by itself. Similar concept that you can see too in the cholestasis of pregnancy. And they have similar genes associated in those two conditions. You can have either one of those three genes mutated and creating the same histology. Important with PFIC3, it will look very similar to BA basically. Doppler reaction and a photofiber expansion with a high GT. Other PFICs, these are super rare. For instance, like PFIC6 is basically case reports. So that description I just took from one of those case reports. So important to know here, you have a couple of more PFIC that have presented with a high GT. In the past, normally high GT we associated mainly with PFIC3, but there are more subtypes now being recognized with a high GT. MYO5B deficiency, important because this patient may have microvillus inclusion disease as well. Some of them may not have microvillus inclusion disease, but that's how the disease was originally identified and described in those patients with microvillus inclusion disease presenting with a cholestasis. And here are some controls photographs of the immunohistochemistry marker that you can use, B7 and DR3. These immunohistochemistry markers are quite challenging to get it to work, and we don't have it here in IU. If I have a case, I just send it to a reference lab. And I suggest doing the same, send it to a reference lab that have a lot of experience with these antibodies, because these are very rare cases and very tricky to make the antibody work perfectly. Okay, so the third pattern, it will be the bile duct paucity pattern. So bile duct paucity is the absence of bile duct. So here you have this podotract, and there you can see your veins, your artery, and there's no well-formed bile duct. And then what is the actual definition? The bile duct to podotract ratio when it's less than 0.5 or less than 50%. To make a count, an official count, you want at least 10 podotracts available for assessment. How to do the count? You can do an H&E or you can get a CK7. I personally do it in my H&E, also in the trichrome and in my PAS with diastase. So I do it in 3 separate slides. And the reason I do those 3 slides, one, the PAS with diastase is actually a very clean slide to review liver. And because the basement member will be highlighted in the bile ducts, it makes it easier sometimes to find those bile ducts. And the other reason that I do it is because those 3 slides, just knowing how my lab code the slides are in 3 different levels. So the H&E will be the first slide that got into the block. The PS with diastase is actually the last slide, and the tracking is right in the middle. So that way I'm doing 3 counts at 3 different time points, like not time points, sorry, different depth into the block. So I'm making sure that they are very similar. There are gonna be some difference, obviously, in the number of podotracts. But if I want to call about the paucity, hopefully my 3 counts will be consistent with that diagnosis. Your normal ratio will be 0.9 to 1.8, except in premature less than 35 weeks of gestation. So these are 2 autopsies. This patient is on 8 weeks, this is at 22 weeks. And I'm just showing this photo to show how the bile ducts actually form. So they form in the limiting plate. At the beginning, you have a single cell line of cuboidal columnar cells. They eventually get a double layer, and eventually that double layer gets dilated, forming like this kind of duct plate configuration. And those that are proximal to the portal line will actually continue to mature. Eventually, will go inside the portal tract and form your definite interlobular bile ducts. Those that are not close to the portal line will just atrophy and just go to apoptosis. And that's important to have that concept in mind, because if you have a kid that was born at 28 weeks gestation and you're looking at the biopsy at 7 weeks age, that patient is still like 35, 36 week gestation embryologically. So it will be normal not to have all your interlobular bile ducts completely formed. So when I see those cases, I do my bile duct count, but I put a comment saying that this could represent your normal embryology, normal formation development of the liver. And I cannot fully label, won't fully label the patient as a bile duct paucity. Something very interesting with the bile duct paucity in neonatal cholestasis, and that you have an abnormal expression of CK7 throughout the liver. Sometimes it's so impressive that the entire liver will look completely black, brown, because there's this aberrant expression of the hepatocytes, which is thought to be just a response of the liver trying to recreate and get that biliary phenotype to create more bile ducts. And by this paper by Dr. Ernst, they found evaluating multiple causes of neonatal cholestasis that only those associated with a bile duct paucity were showing this pattern of CK7. So if you're going to do a biliary marker and you decided between CK7 and CK19, my suggestion is to do a CK7. That's what I do. I don't do a CK19. When the CK7 will add me that information of that biliary, the biliary manipulation is useful when I'm looking at these cases. So your differential diagnosis, you can divide in two groups, syndromic and non-syndromic. Syndromic with your Alagille syndrome. Non-syndromic, HNF1 beta deficiency, again, F1 deficiency. You notice some of these entities are repeating in all the patterns, and that's important to be aware of it. Cystic fibrosis, biliary atresia, and very late presentations. And that's important because if you have a late presentation biliary atresia, you may not have your obstructive pattern and just the paucity, but at that stage, you probably have either stage 3 or stage 4 fibrosis. So Alagille syndrome, autosomal dominant, quite rare, 1 in 100,000 live births. Most of the cases are due to JAK1 mutations, and then 1 or 2% of the cases are due to NOTCH2 mutation. The rest, we still don't know what's the cause. The presentation, chronic cholestasis in most of the patients, some cardiac anomalies such as pulmonary stenosis, your butterfly vertebra as shown here in this photograph, which basically is a sagittal cleft vertebra, so a hemivertebra. Posterior endotoxin shown here in this photograph. And they have a distinct facial features, which is called like a triangular face, and that's due to the small pointed chin, your hypertelorism, and your prominent forehead. So with that, now I want to do a case discussion, and hopefully we can talk a little bit more about your histologic pattern, the clinical history, and how you put everything together. So case 1, so this is 7 weeks old, former 39-week gestational age, intrauterine growth restriction, presenting with jaundice, physical exam, alert, interactive. So liver function. So all these liver function, at least to me when I see them, they're not super helpful for our point of view from pathology. What I'm mainly paying attention is GT. So it's a very high GT, so that's super important for me, because then in my mind, I'm just thinking now that differential diagnosis of high GT. And the sonogram, so gallbladder, common bile duct. So they decided to do a biopsy. Yeah. So this is our biopsy. So looking first at the lobule, there's some acidosis, then you also have some Janssen cell transformation. There's some cholestasis, and I go a closer photo to pay more attention at the photo track. So looking at the photo track, there's a couple of things. One, you are seeing a duct injury. For instance, it's about duct here. There's definitely some duct injury. And there is some cholestasis of bowel blocks within the lumen of this bowel duct too. The other impressive thing that you can really see in your HME is all these refractile black pigment. So that's all iron. So that's a lot of iron deposition here, which is also depositing in the bile duct and also within the parenchyma in the periportal area. So there, then, and yes, I do have photo of the items to make it easier to make it more apparent. So the item also very helpful when you do the iron stain because then you can also confirm all your area of color stains. Unfortunately, this photo, I took a photo with an actual bowel plug at the same plane, so you can like compare the two color difference. But if you look at here, this one is more like yellow, golden, more of like bowel cholestasis. In contrast, the item will look more fractal and black, more darker. So what was our diagnosis for this case? So a bile duct and ductal proliferation with associated cholestasis and rare bowel plaques. And there's a periportal biliary acidosis. So the main important thing to me in this biopsy is I cannot rule out BA. I'm seeing a small bowel plug, and there's a lot of cirrhosis. So that these iron deposition, in my opinion, when you have a very more dense in the periportal area with that gradient, it's usually physiologic iron. And this, especially in these kids very early on, they're doing a lot of extramedullary hematopoiesis in the portal tracts. So it's gonna be more iron depositing in this area. Of course, I put that in my report, but I say I cannot exclude an iron disorder. So I did a cholangiogram. They actually confirmed this was a biliary atresia case. And this is the actual specimen that we got. So we got the fibrous plate and section from that fibrous plate confirmed you have all these abnormally shaped bowel structures and you don't have a well-formed bowel ducts. So all consistent with biliary atresia. This case also happened that the patient had a low level of alpha-1 antitrypsin deficiency, 40, and then usually most lab automatically reflects that to get a phenotype. So this patient also have a diagnosis of alpha-1 antitrypsin deficiency, so both BA and alpha-1 antitrypsin deficiency. In my opinion, it's extremely challenging to evaluate the PAS with diastase in these cases. There is some like non-specific staining here in the periportal area. It's really hard. The important thing to know is what you're staining with your PS with diastase is the abnormally accumulated protein. When you have a kid of 7 weeks, 8 weeks, there hasn't been enough time for the protein to accumulate. So you won't see that classic big globule with a clear halo around that you see mostly in your adult patients. So in our case here, we have a 38 weeks gestational age, jaundice, very similar presentation. But then we look here, DGT actually low. And you have a sonogram with a very distended gallbladder. Looking at the histology, here you see the portal tracts are not expanded. You have some myeloid, some hematopoiesis, there's some erythroids in the lobule, and you have this Janssen cell transformation of hepatocytes with some steatosis. So our diagnosis for this was a Janssen hepatitis with steatosis. There was a retained kind of liquid expression of B7, MDR3, MYO5B, and TJP2. So based on that, we said the eventual diagnosis would be a metabolic disorder given the steatosis or a bile acid synthesis disorder given the presence of a low GT. So this patient was found to have in the cholestatic genetic pattern and homozygous mutation in ARK1D1, which is associated with a deficiency of this enzyme, which defines bile acid synthesis defect type 2. So as mentioned earlier in the talk, a lot of these patients are getting this cholestatic genetic pattern. Unfortunately, for most of them, if not all, I don't have that information at the time I'm reviewing my liver biopsy. But hopefully, when the week after or so, we have it back, and our clinicians are pretty good at giving us that feedback on what turned out to be. In the third case, 39 weeks gestational age, jaundice, acolic stools, similar kind of presentation. Looking at GT is kind of high, not super high. You have a narrow common bile duct, hepatic angiography, no biliary excretion. So all of these are really red flags for biliary atresia. So before they went ahead and did a cholangiogram, they did a biopsy. So in the biopsy, you have your portal tracts. There's actually no bile ducts. There's a lot of cholestasis in the lobium, some subacin information there, and some Janssen transformation there hepatocytes. But looking very closely, and there was actually a bile duct paucity. So there was a bile duct paucity pattern. And that's how we sign out this case of bile duct paucity with associated low-grade cholestasis. And the patient was found to have a JAK1 mutation consistent with analysis of Alagille syndrome, and also had a mutation in UGT1A1 mutation we associated with Crigler-Najjar syndrome, which is interesting. Could it possible that some of the cholestasis be due to this mutation of the Crigler-Najjar and some of the other passive like that when you have the two diseases simultaneously? I don't know, but we can definitely reassure ourselves it's about the positive pattern, JAK1, all consistent with Alagille syndrome, and the key importance of doing this liver biopsy before taking your patient to a cholangiogram. Because if the patient would have done a would have seen a cholangiogram and it was being abnormal, the patient would get like a side, and that would be really bad for this patient. So in conclusion, neonatal cholestasis has a very broad differential diagnosis, and we can divide it in a very practical approach as low and normal GT and high GT. Certain diagnoses require a very timely diagnosis. So in these photographs, we're emphasizing that obstructive pattern. You have your ductular reaction and your valve plugs in the valve plugs in the lumen of the ductules. So it's telling me there's an obstructive process, importantly, pediatrician, among the differential diagnosis. I should emphasize, and you probably saw that based on the differential diagnosis of each pattern, you cannot diagnose PA on your liver biopsy. You should diagnose the histology pattern that is associated to PA, and the clinician need to keep doing their workup. And liver biopsy plays a key role in the evaluation of these patients. And when you see these liver biopsies, identify the pattern, and that's how I usually sign them out. I just call it the pattern, signal is my differential diagnosis. And with that, thank you so much for your attention, and I'll be happy to take any questions.
Yeah, thanks everyone for joining us today. We can take questions now in the Q&A. We have one already, Dr. Gonzalez. Someone has asked if you could show your diagnostic algorithm for workup. Dr. Gonzalez, you can probably see these questions as well. We've had one more come in after that.
So let me just share my screen. Is it right? So this is probably what they want, like to share this algorithm. Yeah. So this algorithm is, just keep in mind that I'm doing a lot of generalizations here, and that's just for most center probably use something along those lines, but it will be very dependent on your specific center. My best advice would be have a close relationship with your hepatologist and figure out how they work up these cases. And yeah, good to guys. Usually when they do these hour-based biopsies in our center, we usually stop by and we discuss the case in person, look at the slides together, and then just try to put everything together. Okay, can you put the slide with all findings of PA positive and negative question about how we were the common where there are negative findings? So I think they're referring to this really great study by Dr. Russo. So this study is super interesting. They sit down together, the children network, a bunch of pathologists, I think 15 plus or so pathologists. They review, if I remember correctly, the numbers close to 400 biopsies, and evaluated all these different features and trying to determine which were associated with PA and which weren't. So how strongly you were the comment when there are negative findings. So if I have a case and I'm seeing all these features and I don't see bowel plugs or about ductular reaction, I was just saying in my note that I do not see features to suggest an obstructive process. So I actually use a very strong language if I don't see anything that is used LBA. And I'll just mention, for instance, Janssen hepatitis pattern, C note. And then in my note, I will say there are no features to suggest an obstructive process. And with that, that will guide my clinicians right away how to continue to work up these patients. Role of MMP7, which I'm gonna guess they're talking about and please correct me who asked the question. They're looking for the IC, the recent paper talking about Wilson's disease. I don't have it available in my lab. Oh no, sorry. No, never mind. So you're talking about the serum level of MMP7 for pediatrician. Yes. So our clinicians, they actually do it occasionally, not always. And they told me that originally it was being done by this clinical research lab. I think they like switch centers and it was more challenging now for them to get it. So they only use it and find it useful if it's like they are not like very high, but if not, it's not, they don't find it very useful. So it's just one more tool that they like to have before they take this patient for a cholangiogram, but our clinicians don't put a lot of weight on it. What do you think right now is a cystic BA? So yeah, so cystic BA will be when you have fibrous play and then you have a dilatation of the bowel duct system. They're quite rare. I think last year we only had 2 cases here in my institution. They're quite interesting how the cystic structure form. But when you submit your sections and we submit it entirely, you actually find a fibrous plate, an area where there's no bowel duct formation, where you actually have your diagnosis of pediatrician. Your main differential of a cystic BA will be a choledochosis. And then the main thing to differentiate them will be one, your absence of fibrous plate in the case of choledochosis, and your gallbladder. If your gallbladder is completely atrophied, that will be more likely a cystic BA. And if it is not, then it was more likely to be choledochosis. The actual histology of the actual cystic portion, in my opinion, won't help you. In both cases, you can have a kind of muscular swell that can have your columnar epithelium with even some glands, epithelial glands. So it won't be that helpful. The most helpful will be having section of your fibrous plate and looking at the specimen grossly. Cystic BA is like roughly less than 1% or so of the cases is very rare. Am I missing questions?
Yeah, feel
Yes.
free to add any further questions that you have. We'll give you guys a few minutes. I just want to emphasize again as well that for those interested in claiming CME credits, that an email will follow today's presentation with information on how to do that. All right, so if we don't have any further questions, we are going to wrap up. And thank you so much, Dr. Gonzalez, for this excellent talk. When I turn off the webinar, everyone, it'll just immediately kick you out. So please don't be discouraged by the thought that you're just thrown right out of here. But thank you guys all for attending. Have a great rest of your day.
Cool. Thank you. Thanks.